Welcome to Cosmetic Networks Live, where we explore the aesthetic and the cosmetic industry from the inside out. Hi, I'm your host, Sheila Maitland, and this is Thursday, May 23rd, 2014, episode 93. Our special guest today is Dr. Douglas Hendricks, board-certified plastic surgeon in Newport Beach. Welcome, Dr. Hendricks.
Thank you, Sheila. Thanks for having me.
We're so glad you're on the show today. We have some really great information and that you're going to share, and some topics that the viewers are going to be just so not only interested, but they need to know. So let's start with the biggest misconceptions in Smartlipo. For example, the difference between general anesthesia and local anesthesia. So why are some doctors doing liposuction under a local anesthesia and you choose to do it under a general anesthesia?
It's a good question. As we talked about, I am a big proponent of this technology. It's a great technology. It's something that's done by no other device that we know of, and that is to tighten skin. And it tightens skin from underneath the skin. With one little opening, the laser fiber can go underneath the skin and can cause that to tighten. In places that otherwise would have to be either left or would have to be snipped away and sewn together, leaving a large unsightly scar. So it's an alternative to doing that. So I use that in a lot of particular situations where, for example, somebody has loose skin after having a baby or after loss of large amounts of weight. It's a powerful laser. It's undergone 7 or 8 upgrades in the power. And you know, I have some patients that come into the office, and we talk about the technology. They're comparing, and sometimes they're even price shopping. And I understand that price is important. There are these machines that have been sold and are being used by doctors who are not surgeons, or not trained as surgeons. So therefore, in the state of California and in every state in the United States, they can't actually, even if you wanted to be asleep because you said, I don't want to see that, I don't want to hear those noises, I just want to wake up and have it done, they would say, I can't do that, I'm not allowed to do that because I'm not trained as a surgeon. Well, there's a red flag right there, and that's a good question to ask. What I found, some patients will say, I have this fear of going to sleep, whatever the reason is, and we can maybe explore that question. But I've agreed to allow to do the procedure with them sedated in the operating room, with an anesthesiologist monitoring their vital signs while I focus on the procedure, which is an extra added layer of safety. What I found is that I cannot use the full power of the machine, and I have to turn it down no matter how much local anesthesia that I inject to try to numb the area.
So they're not getting the full benefit of the results that you could perform for them if they allowed you or were confident by being educated and understanding the value of going under a general anesthetic.
That's correct. I think having this particular technology, this particular procedure in an office is a compromise. It's a compromise because of the dangers of local anesthesia. We'll talk about that. But also, it's a compromise because I think that the amount of energy or the degree of treatment that you're paying for and getting is less than what the machine can fully provide. So they have to compromise on what they can do comfortably with you awake, and then also with the amount of power that they can use on the machine. So I think it's a compromise all the way around. You know, this is why it cost a bit more to have me do the surgery, because the extra added cost of the anesthesia and the operating room. But that's for a full, complete treatment, avoiding the scars and avoiding, you know, not having a result, I guess, is the other downside.
So Dr. Hendricks, if a patient goes to a physician and they inquire about Smartlipo, and the physician says, I only do mine under local because I believe this is the best way, is there a possibility that that physician is saying that because they don't have the surgery center privileges to do, or even the anesthetic general anesthesia connections to do it under a general?
That's absolutely true. They would, they basically could not get privileges to put you to sleep because they're not trained as a surgeon. Maybe they're trained as a dermatologist or trained as an ER doctor, or maybe they're an OBGYN who has decided to take up and start doing Smartlipo for extra income in their office. And technically they have privileges in the hospital to do surgery, but episiotomies and deliveries and C-sections and D&Cs, they have privileges for that, but they don't have privileges to put you to sleep to do cosmetic surgery. So I think it's important, it's a way to sort of flush out who's really legitimately trained as a surgeon, qualified as a surgeon, able to offer you the full spectrum of care rather than just sort of his flavor of treatment, which is limited because his training is limited.
So then if a patient hears a physician make a statement like that and they really need to be thinking safety first, they need to hear that could possibly be a red flag.
That's absolutely right.
So let's talk about who is actually qualified to perform Smartlipo procedure.
Really, first of all, this is my opinion, but my opinion being that this needs to be done under general anesthesia to be able to turn the laser up to the power that is an effective power. Second of all, who's qualified is somebody who has received a training course by the company themselves. Now, I'm a trainer, a national trainer for the company, and technically they do not mail the keys for the laser to anybody who hasn't gone through the training course. Granted, that training course is just a day where the doctor will travel around with me and they'll learn about before and after care, and they'll learn about, you know, selecting proper candidates. But I limit the people that they send to me to people who have a strong foundation and that are plastic surgeons, not a family practice doctor or anybody else really who is not trained in all facets of plastic surgery. So that's really the foundation. That's not my opinion, that I think that you've got to be a surgeon with training in surgery. You have to have privileges in a local hospital or in an outpatient surgery center to do surgery because at least surgery in an outpatient surgery center is shown to be the safest with the lowest risk of infection, the lowest risk of complications. And if the only choice that this physician offers you is someplace in his office, then you ought to smell day-old fish because something is not on the up and up. And having surgery in a doctor's office is probably the most dangerous thing you could do. Those physicians aren't necessarily, the office has not necessarily been inspected because they haven't listed or registered themselves as a surgery center or as a place where surgery is done. You don't know what equipment is being reused or how the sterilization is. You just don't know about the technique. They have no regulations to follow because they're really not regulated. They're not known as a surgery center. And then you have one doctor who's trying to do his best at anesthetizing you and doing a proper laser treatment and monitoring your vital signs and your overall condition to make sure that you're safe and comfortable. So it's a lot to handle, and it's I mean, that's why it's so inexpensive. So the saying in my office is that cheap surgery is expensive.
Yes.
Because there can be so many different hazards. I mean, the least of which is an inadequate or a less than satisfactory result, all the way up to minor to major complications.
And then the money it takes to repair all those problems that were done for a less price.
Absolutely, absolutely.
So Dr. Hendricks, share with the viewers why you're so passionate about this technology of Smartlipo.
Well, I'm a renegade, let's just put it that way, in a way. I like things that are certainly clinically proven, but things that are really on the forefront. It's easy to do the same thing that I was trained to do 20 years ago, 25 years ago, and unfortunately I see many of my colleagues will do that. They get in a comfort zone, maybe minor variations on the theme or what they were doing, but really thinking outside the box. How can this be done better? How can this be done more efficiently? How can it be done in a way that maybe is less time, maybe is it gives a better result? There's always options for that. Technology is advancing, surgery should be advancing.
Right. You know, let's jump back into the conversation about the local and general anesthesia in regards to what are some of the fears and the reservations and concerns between local anesthesia and general anesthesia versus a heavy sedation or a deep sedation?
Loaded question. Good. And many facets of that. Let me just put it this way, that local anesthesia is injection of a compound. It's called lidocaine, usually is the one that's most commonly used. What many patients don't know is that lidocaine can be very toxic. In fact, there are many reports of people who have had a lidocaine overdose. Lidocaine is a muscle and nerve blocker, and if a high enough level gets into your system, then that can cause your heart to stop or your heart to arrest. Now, unfortunately, what happens is you may have a low level in the operating room, and then 6 hours later, that level, as it's coming out of the tissue and being absorbed into the bloodstream, can reach a very toxic level long after you're gone from the surgery center. I have in front of me, I brought in today a bottle of lidocaine, and actually 3 bottles. Now, this is, if this amount of lidocaine, and it's always diluted in some liquid, in some saline, but this amount of lidocaine, this is 2%. I mean, not very concentrated, but that amount of lidocaine injected in one particular session, whether it's diluted or not, that quantity in terms of milligrams, that can is enough to cause a cardiac arrest or basically for someone to stop breathing. So my concern or my intuition about some of these deaths from lidocaine is that these are patients that have really been given more lidocaine because it's been difficult. They've been difficult to anesthetize, or maybe everything is numb, but one particular small area, and it keeps getting re-injected and re-injected, and all of a sudden they're over the limit of what they can inject. Say they've finished treating one thigh, and the other thigh they can't get numb, and they don't want the patient to leave the operating room with one side done and one side not done. So they keep injecting to try to get numb, and then all of a sudden they're over the limit. And those are the kind of situations that are very, very dangerous. When I do surgery, of course I have the general anesthesia backup, and I want patients to be comfortable after they go home. So these can last for many hours in your system. I will inject some lidocaine under the skin in the area that I'm treating, so they have they're more comfortable when they wake up. But I only allow the nurse to bring in the maximum amount in the bottle into the room, and so no more is brought into the room after that. So we're sort of doubly and triply certain that we haven't gone over the limit or the maximum amount. And if an area is maybe the patient is asleep, so they're getting treated, they're getting the complete treatment, and they may just be a little bit more uncomfortable in that area when they wake up, but I know that they haven't received a toxic dose. And if this is the only thing that I have to allow me to do the procedure, and it's not enough, then there's some tough decisions that doctors who box themselves into that corner have to make.
So it sounds to me that it's a much safer all-around experience to pick the general anesthetic. And I think there's a misconception that people have about general anesthesia because they don't want to go under. They're afraid they'll never wake up. But from some of the articles I've been reading, it's healthier on the body because the body's not in such trauma. It's more relaxed. It doesn't feel anything. Or if the patient's under a local, I'm hearing about these people waking up and can't speaking, but they can feel everything going on because they aren't sedated enough throughout the entire body.
Right. I think those situations occur. If you think about the comparison, general anesthesia is a sedative. That's all it is. And it's a sedative to the point where, just below the point where your brain and your lungs are not connected in a way that your body senses when it's time to take another breath. Now, deep sedation is just one level above that. I mean, people that are very deeply intoxicated from alcohol or from overdoses of drugs, the same situation. And when somebody dies from an overdose, they're sedated basically to the point of general anesthesia. They don't breathe, and so there's no oxygen to the brain, and then eventually the heart stops. Right. So basically what an anesthesiologist will do is give a patient enough sedation so that they're asleep and they're comfortable, and their body, the nerves are not transmitting pain signals to the brain. We put in what I call a snorkel, but it's just a plastic tube actually that goes past the tongue, holds the tongue out of the way, and puts in breaths into the lungs. Now, there are machines in the operating room. They register. If you're taking normal breaths, then the machine doesn't breathe for you. But if you are not taking a breath when you're supposed to, then the machine will kick in a breath. So that's automatic. Right. I mean, that to me is very safe. If you look at the numbers, you know, the risks of death from anesthesia, it's between 1 in 200,000 and 1 in 300,000 people. I mean, it's extraordinarily small, and that one is probably from equipment malfunction or something, you know, really odd and out of the ordinary. The risk is not with the general anesthesia. That's where people get confused. The danger is really with the risk of surgery, because surgery can result in complications. Surgery can, after all, it's not anesthesia that causes the bleeding or the hematoma or the infection. It's the surgery part of it that does that. The risk of death or major complication in plastic surgery is about 1 in 53,000. Now, it's interesting because that's about the same risk of dying as it is as having a child or childbirth. So, you know, people don't think about dying when they get pregnant and they're, you know, they are go to the hospital to deliver their baby. Although we all sign consents that says, I understand that there's a risk of dying, there's a risk of complications. The same percentage risk is associated in general with cosmetic surgery. It's so low because cosmetic surgery in general will operate on healthy people. Right. I mean, we have laws in the state of California that require an independent physician to perform an examination on a patient and make sure that they're optimal, that they're healthy, that they're, you know, in the best shape that they can, that all systems are go to undergo an elective operation like this, because after all, it's a choice. Right. So these are the healthiest of the healthy people. You hear disasters really when those rules aren't followed, or when something else intervenes. Usually there's something else that comes to play, but it's a very, very rare instance.